He's talking non-invasive transcutaneous neuromodular.
अभी चल रहा है क्या तुम्हारा? That's fine. एक मिनट. Yeah, so we're going to be talking about transcutaneous non-invasive neuromodulation therapies. So basically when we talk about neuromodulation, it is the alteration of any nerve activity through targeted delivery of a stimulus. So whether it is electrical stimulation, whether it is a chemical agent to specific sites within the body. So you want to modulate, so that's either normalize or to attenuate nervous tissue function. Now, we've been talking about spinal cord stimulation, we've been talking about RF, all of these are neuromodulatory modalities. One that we haven't talked about is percutaneous or transcutaneous modulation. So in this presentation, we're just going to run through this quickly. What are the different techniques? What are the outcomes vis-a-vis invasive modulatory therapies? And what is their clinical application? Now, there's a lot of focus recently on using certain approaches when it comes to non-invasive neuromodulation. Primarily, we are looking at either the vagus nerve or the sacral complex. So whenever you have neuromodulation, like the previous speakers said so beautifully, the problem is achieving a clinically relevant therapeutic endpoint, having it stick, optimizing the location where you stimulate, optimizing the parameters of stimulation, and the miscellaneous off-target effects that you get. These are the major concerns whenever you talk about any form of neuromodulation. So now when we're talking about non-invasive neuromodulation, broadly we can divide it into cranial versus peripheral. Cranial, we'll talk about either transcranial magnetic stimulation or MR-guided focused ultrasound, and that is beyond the scope of our discussion today. What we will talk about is vagal, sacral, and posterior tibial nerve modulation. Now, when you talk about the vagus nerve complex and the sacral nerve complex, there's a lot of research about this, because whenever you stimulate these directly, so vagal nerve stimulation or sacral nerve stimulation, this has been approved for epilepsy, it's been approved for major depressive disorder. When you look at sacral nerve modulation, it's been approved for overactive bladder, urinary retention, fecal incontinence. So these are very attractive targets, primarily because for a single nervous complex, they innervate an extremely wide area of tissue. Now, vagal nerve stimulation alone, so the indications can be neurological like migraine or epilepsy, and this can be either invasive or non-invasive, major depressive disorder, chronic tinnitus. A lot of the work we are doing at our hospital is on cardiac and GI neuromodulation, whether it be invasive or non-invasive. So we've been doing a lot of vagal nerve stimulation for conditions like arrhythmogenicity, atrial fibrillation, heart failure with reduced or preserved ejection fraction. GI neuromodulation, and we'll come to that, is patients with functional GI disorders, patients with dysynergic defecation, IBS, Crohn's disease. So a lot of this therapeutic mechanism of when you stimulate the vagus nerve peripherally, and that's primarily through the ear, is thought to be mediated by concentration shifts of norepinephrine, GABA, as well as acetylcholine within the CNS. So these concentration shifts will lead to changes within the cerebral cortex and alter neuroplasticity. Now, all of us know about the vagus nerve, so it's a major component of the autonomic nervous system, important role in metabolic homeostasis. Neuroendocrine immune axis is another major role through afferent as well as efferent pathways. Now, left cervical vagal nerve stimulation is something that all of you are very familiar with, because vagal nerve stimulators are available for refractory epilepsy as well as major depressive disorders. Right cervical vagus nerve stimulation is the area of interest where you're talking about heart failure as well as GI disorders. Now, the ear basically is an attractive target for when you want to do vagal nerve stimulation, because it's got an extremely complex innervation. It's been innervated by the auriculotemporal, the vagus, as well as the greater auricular nerves. Now, this is basically a relay station that affects other brain areas which are involved in autonomic control as well as pain. So projections of these vagus nerve extend to the ventral medulla, hypothalamus, amygdala, and spinal cord. So this is why when you do a peripheral field stimulation of the vagus nerve near the ear, you can have alterations in neuroplasticity as well as firing rate within the amygdala as well as spinal neurons. So you have significant modulation at the spinal, at the dorsal root level, as well as at the central level. Now, when you talk about the ear, so the anterior superior aspect of the ear is innervated by the auriculotemporal nerve. The inferior wall is innervated by the greater auricular nerve. Now, the superior ganglion of the vagus nerve will give off two branches, and this will innervate basically the posterior superior wall of the acoustic meatus. Now, this area is primarily called the cymba conchae as well as the concha. So, these are the targets which we use for auricular vagal nerve stimulation. So when we talked about the auricular branch of the vagus nerve, as soon as it comes out of the jugular ganglion, it basically accompanies the inferior ganglion of the glossopharyngeal nerve. And then it will ascend through the lateral surface of the jugular fossa and run along the temporal bone. So within the mastoid, after that, it will basically course over the canal above the sphenomastoid foramen and then divides into two branches, which is what we talked about. The first branch is going to give off branches to the dura mater, and it has a connection with the chorda tympani, which is a branch of the facial nerve. The second branch will give off two small nerves. One of them connects to the posterior auricular nerve, and the second one innervates the posterior inferior or posterior superior skin of the external auditory canal and the tympanic membrane. Now, this is the nerve we are primarily targeting, the second branch of the vagus nerve. Now, there are a lot of treatment modalities which are available for vagal nerve stimulation. So this is a device which was called Gammacore. It's non-invasive neuromodulation which is applied directly to the neck, and it's being used for refractory migraine. This is a device which is in development where you attach it behind the helix, and this is what we have been using at our hospital. These aren't commercially available. They actually need to be imported from Australia, but essentially it's a clip, and the clip attaches over the cymba conchae or over the tragus. And what you're doing there is you're going to stimulate this constantly with a TENS device, a commercially available TENS device with stimulation parameters of your choosing. And the stimulus intensity is set to whatever the patient can tolerate. And this tolerance is going to keep increasing with duration. Now, when we're doing this in the vagus complex, what we're looking at is cardiovascular, GI, as well as immune modulation. So antidepressant effect of the vagus nerve stimulation. So you have alternation of the connectivity of the default mode network. Like we said, there is a lot of change in the firing of the amygdala, hippocampus, and the hypothalamus. So you have a significant effect on patients with major depressive disorder. Cardiac applications. One of the primary reasons for many cardiovascular disease is an elevated sympathetic drive. So whether it is heart failure, whether it is hypertension, whether it is atrial fibrillation, ultimately what we're looking at is a hyperadrenergic status. So when you do electrical stimulation of the inner tragus, which is this vagal nerve stimulation, you activate parasympathetic efferents, and what it has been seen is you have reduced heart rate, you have reduced episodes of atrial fibrillation, and improved heart rate variability. So this again is a interesting area of research where as far as cardiac conditions are concerned. When we talk about GI neuromodulation, which is what I said we're doing, auricular neurostimulation in adolescents with irritable bowel syndrome improves abdominal pain scores, improves consumption of narcotics, improves depression scores. So you're looking at overall improved quality of life as far as these patients are concerned. When you look at functional gastrointestinal disorders in adolescent patients, you're not really looking to intervene too much in this patient group. And again, you have improved functional outcomes, you have improved cognitive scores, and as compared to sham. Now, when it comes to PTNS stimulation, so because it's very closely associated with the tibial artery, the tibial nerve is called the posterior tibial nerve. So it basically originates from the L4 to S3 roots, which are composed of motor as well as sensory fibers. So now the interesting part is pelvic floor muscles, bladder sphincters, bladder destrusor muscles are all innervated by the same root values. So now when the posterior tibial nerve is so easily accessible, it provides a very interesting area when you want to stimulate it. So the exact mechanism is unclear, but the logic being because the sacral plexus has the same root value and because the posterior tibial nerve is a branch of the sciatic nerve, retrograde stimulation of this nerve will provide neuromodulation of afferent pathways to the bladder. So patients with overactive bladder, incontinence or fecal incontinence who do not respond well to conservative or pharmacological therapies are quite good candidates as far as percutaneous or transcutaneous tibial nerve stimulation are concerned. there is a device by Medtronic which is still not available in India. But again, conventional TENS devices can also be used to stimulate with reasonable effects. Now, as far as evidence is concerned, urinary incontinence and overactive bladder, urge incontinence, there is quite excellent literature to suggest that transcutaneous as well as percutaneous cerebral nerve stimulation leads to good outcomes. Home-based, this is one major advantage. The patient doesn't have to come to the hospital. A TENS machine is relatively cheap, and it basically involves 30-minute sessions daily for about 8 to 12 weeks. Compliance is usually not an issue. And when you measure it with metrics like urodynamic studies, usually the patients will have pretty good outcomes. Transcutaneous sacral nerve stimulation, like we said, you can stimulate the posterior tibial nerve in the leg. You can stimulate the sacral nervous complex directly over the foramina. So again, the same patient population per se, overactive bladder in children. So they had a study which compared transcutaneous sacral nerve stimulation versus oxybutynin. And what they concluded is that they were both very effective therapies as far as pediatric overactive bladder is concerned. So, but electrotherapy was shown to be more effective over a prolonged duration of time. Thank you.